All right. Um, Nice to see you all and to see some of you all again after Saturday. Um, and today we have got Chelsea Cogan presenting on treating post-trauma nightmares. So I will go ahead and let her get started.
Awesome. Hi, everyone. Give me a second while I get the screen set up. All right. Things looking good? Perfect. So, thank you for the introduction. My name is Chelsea Cogan, and I am one of the new hires here at PSM. I'm so excited to be here, and I'm even more excited to be presenting on one of my favorite topics, which is treating nightmares. I've jokingly been called the nightmare girl, but not that kind of nightmare girl by my colleagues before. So without further ado, I figure we'll just dive in. But if any questions come up throughout the presentation, I'll make sure we leave time at the end to ask questions. And I'm always happy to talk about nightmares, really anytime. So if we run out of time at the end, please let me know.
And Chelsea, is it okay if we record this?
Yeah,
Lauren
absolutely.
can record for us. All right, thank you.
Okay, so before we dive into nightmares, I figured we could briefly review post-traumatic stress disorder, since that is a key piece in treating post-trauma nightmares, is figuring out, does this person meet criteria for either PTSD or other stressor traumatic related disorder? So in order to meet diagnostic criteria for PTSD, a person has to experience a criterion A stressor, but then there are a number of other symptoms that fall into place for people who have PTSD. And they tend to fall in these 4 different symptom clusters that the DSM has nicely laid out for us that include the arousal symptom cluster. So this is where we see kind of that hypervigilance, exaggerated startle response, difficulties with concentration. We also see sleep disturbance here in the form of difficulties falling asleep or difficulties staying asleep or waking up too early. So symptoms that look fairly consistent with insomnia. We also have the re-experiencing symptom cluster. So here is where we see those intrusive memories of the traumatic event or events. So this could be a person is sitting on the couch, minding their own business, not trying to think about much of anything, and then boom, they have a memory of the trauma. We also see strong emotional reactions or physical reactions to reminders of the trauma in this symptom cluster. And most importantly for our discussion today, we see nightmares falling in here in the re-experiencing symptom cluster. We also see the avoidance symptom cluster, which is avoiding people, places, situations that remind the individual of the trauma. And I'd argue that this other place where we see avoidance of avoiding thinking or feeling about the trauma tends to be part of why we see nightmares occur. And I'll get to that in a little bit. Then finally, we have the negative alterations in cognitions and emotions symptom cluster. So changes in the way people feel and think after a trauma typically see increased sadness, anger, guilt, changes in the way people think, such as, it's my fault the trauma happened, no one is safe, the world entirely isn't safe. So as I've kind of walked us through these symptom clusters, one thing I want to point out is that sleep disturbance shows up in 2 of them. The arousal and the re-experiencing symptom clusters is where we see sleep disturbance come into play for people with PTSD. And there is a lot of literature out there to suggest that sleep disturbance is considered to be the hallmark of PTSD. And essentially what that means is that if someone has experienced a traumatic event, 9 times out of 10, when they're reporting all the various different symptoms that they could related to PTSD, they're going to be reporting sleep disturbance in some capacity. That is something that shows up time and time again. And another really important consideration with post-trauma or post-traumatic sleep disturbance is that We don't necessarily see a full remittance in this with a course of trauma-focused care, which signifies that maybe there's something that we should be doing to treat these on their own. Because I would argue that, say you have someone coming in for cognitive processing therapy or prolonged exposure, and they see huge changes in their PTSD scores and symptoms. On the PCL, you're noticing everything decreasing, but you're noticing they're still having nightmares, or they're having difficulties falling asleep or staying asleep. Even if they're seeing big changes in those other areas of their life, if they're still having difficulties with sleep, their overall functioning probably isn't that great. So we want to see changes in sleep as well as those other symptoms. So I've been alluding to this whole time, but we often see both insomnia and nightmares as common sleep disturbances following trauma. And I want to talk a little bit about how these look different, as well as how they can kind of show up in similar ways in someone who has experienced a traumatic event with or without PTSD. So in terms of insomnia, here we think traditionally of those difficulties falling asleep, staying asleep, or waking up too early, or if you're really unlucky, all three of those. And in a diagnosis of insomnia disorder, we would want to be seeing some concerns around the sleep quality and quantity for the individual, so some clinical significance there. However, one of the things to note about insomnia and sleep disturbance in the literature is that it's actually really difficult with insomnia in particular to capture the true prevalence and incident rates for these, because so many people use the term insomnia to mean not only symptoms, but the full-blown disorder as well. So it makes it really hard to nail down how often this is showing up for people and when it's showing up for people. All of that to say, though, up to 70% of people with PTSD experience symptoms of insomnia. Not necessarily full insomnia disorder, but they have those symptoms. So they might have those difficulties with falling asleep or staying asleep. And in a way, I'd argue that oftentimes these can show up around nightmares as well. So maybe the person is scared to go to sleep because they're worried they're going to have a nightmare, or maybe they wake up after a nightmare and just can't get back to sleep and decide I'm just up for the day, right? So it may be that the person is having nightmares and they're showing up. They feel more comfortable telling you about the insomnia type symptoms as opposed to the nightmares, because oftentimes people can be a little bit embarrassed about the nightmares because we think of them as something that kids have, but that's not the case. They show up a lot for people who have experienced a trauma. So let's talk about the types of nightmares, because there are actually different types. And this is where I start to really kind of geek out about nightmares and get a little bit into the weeds, but not too much. I promise I won't go off the rails here. We'll get to the actual treatment as well. But in terms of nightmares, we have idiopathic nightmares, and these are the ones that don't necessarily have a root cause. There's nothing that we can point to and be like, that's where it started. That's why I have this nightmare. And these types of nightmares impact roughly like 5 to 8% of the general population at any given time. So not a huge concern, but it's showing up. And I would argue in large part because most of us have had at least one nightmare. Right? This is part of development. We have them in childhood. Sometimes we have them in adulthood for no known reason. They just happen. It doesn't create a cycle of disruption in our sleep, and we go about our lives. But for other people who have experienced a trauma, they might have post-trauma nightmares, which is a little bit different. So these nightmares occur following a traumatic event. So we can point to a point in time where maybe they weren't having nightmares and then a trauma happened and now they're having nightmares. And trauma or post-trauma nightmares can fall into like 3 different categories. So they can be trauma replicative, which essentially means that the person, when they're having this nightmare, is having a full replay of the traumatic event from start to finish. It's as though they are being transported back to the trauma itself, and as though they're reliving it. can also be trauma similar. So this might mean, I like to use a VA example here because I worked for quite some time in the VA, but maybe we have a veteran whose traumatic experience was they were on deployment, driving down the road, hit an IED and got blown up. Maybe now their nightmare is that they're driving down I-95 with their wife and kid in the car, and they hit something and their car blows up. So it's not the exact same trauma, but it's similar. They're able to make those connections. It's starting to pull in their day-to-day life. Lastly, post-trauma nightmares can be dissimilar to the trauma. So maybe that same veteran is now having a nightmare where they are being chased through a hospital by Furbies. That was an actual nightmare I had as a young child. But so maybe it's dissimilar to the trauma, right? It's not being blown up in Iraq. It's entirely different, but it's still waking that person up. And when I've done this work clinically, I do tend to see that there might be some sort of connection under the surface that maybe the person isn't entirely aware of, right? So maybe there is some concern about safety that's underlying and is that link between the trauma and the nightmare that the person just isn't aware of. But on the surface, it doesn't seem similar to the trauma. So now that we've talked a little bit about nightmares, I figured I would define them finally, because this can also be a point of contention in the field. So nightmares are bad dreams with strong emotional content that wake you up from sleep. I bolded that piece because in the field, there are kind of two camps on this. Some people say it doesn't have to wake you up, other people do. And I go with the definition around it needs to wake you up because the thing is, in order to treat nightmares, you have to remember it. And if you're sleeping through it, you're not going to remember it. You may remember that you had an upsetting dream or a bad dream and it caused you some distress and you didn't really feel great when you woke up. But with nightmares, it wakes you up at the scariest point of the nightmare typically, and you're able to recall it. So I'm of the mindset that it does need to wake you up, especially if we're going to treat it. So upon awakening, not only are they able to recall the dream or the nightmare, but the individual often experiences several physical and emotional symptoms, right? So they might wake up, and I always jokingly refer to it as they might have sweat the bed, right? They wake up in a puddle of their sweat. They wake up and their heart is racing. They're having difficulty breathing. They're feeling very disoriented. They might feel really intense sadness or fear, right? And those things together can make it really hard to fall back asleep. It often takes the body quite some time to come back to baseline and to start to feel better, to go to sleep. And so that's where some of that overlap between those insomnia type symptoms and nightmares shows up for folks. And this statistic is really something that stands out to me, is that up to 90% of people who have experienced a trauma experience nightmares at some point. So it could either be an ongoing issue, or maybe it's something that they are experiencing right after the trauma and it doesn't hang on as much. But this goes back to, it's part of the hallmark symptoms of PTSD. Most people that you talk to who have had a traumatic experience will have some experience with nightmares. They just may not tell you about it right away. But it's always worth asking.
We have a question here about the difference between night terrors and nightmares.
Absolutely. So nightmares, again, are something that wakes you up and you can recall it. Night terrors typically are like, they happen in children, young adults, adolescents, that age group. And what it is, it's usually called a night terror because it terrifies everyone around the person, but the person it's happening to doesn't necessarily know it's happening. Sometimes the person is really difficult to wake. When you finally get them woken up, if you do, you're like, what was happening? Are you okay? They're like, why are you waking me up? So they aren't necessarily having a nightmare or any dream that's creating it. It's just something that's happening in the body and doesn't necessarily have a root cause. But I will say that talking to people who have nightmares, sometimes they'll be like, well, I have night terrors, because they're trying to stress how upsetting it is for them. So I oftentimes will hear clients say like, oh yeah, I have nightmares, they're bad dreams, but then I have like real night terrors and I'm like acting out my dreams and I wake up thrashing around. I'm like, that's still a nightmare. But really good question. Any other questions?
That's all so far.
All right, awesome. So why is it that we have nightmares is another piece of treating them, right? Because we want to know how we're seeing this change, like why people are having them and then how we fix them. We actually don't even really know why it is that we dream. So if we don't know that, we definitely don't know exactly why it is that we have nightmares, but there's some solid theories that I can get behind enough to present them to you all on why it is that people might have nightmares. So one theory is emotion matching. And essentially what this means is if you're really stressed, if you're really angry, sad, have a strong emotion before you go to bed, your brain is trying to create a story to match that emotion. Right? So maybe a person throughout the day who has PTSD or who has experienced a trauma has been dealing with a lot of guilt. They've been feeling really guilty about things or really sad. Their brain is going to pick up on that as they start to go to sleep and be like, okay, so we got to make a story to match this. We got to pull it together, even though you don't want to be dreaming about something that's sad and guilty. So that could be a reason why we're seeing people have nightmares. Another piece is this idea that your brain is trying to solve, I put that in quotations because it's very important. So your brain's trying to solve the trauma. And what I mean here is that, say you have something around the house or something in your car that needs to be fixed, but you just haven't gotten around to it yet. As you go throughout your day, you're going to keep thinking about it. An example I give here is that I used to have an issue with my car where the low tire pressure light would come on constantly, even if the tires were fine. And I'd have to take it into the shop to get it fixed. And it was a whole hassle. And so anytime that light would come on, I'd start thinking about it. When I'd walk to my car, I'd be thinking about that light's going to be on. I have to do something about it. I'd be driving. Okay, that's a shop I can take it to after work. I'll do it today, right? Get to work, get back in my car. I'm like, I'm feeling tired, but I've got to do it. I drive past the shop and I'm like, I'll do it tomorrow, right? All of my time is spent thinking about it when I'm not necessarily doing it. And it's because our brain goes back to things that we haven't fixed, that don't have a resolution. And when you throw in a traumatic event that doesn't have a resolution, there's no quick fix for it. There's no way to solve it. By definition, trauma is chaotic and unexpected and harmful, right? There's no solution. And then you start to avoid thinking or feeling about it because it's upsetting. You start to avoid things that remind you of it. So your brain is staying distracted and away from it all day. At night, your brain is like, you know what's a great time or a great thing I could do right now is I could go back. I could try to fix that. I could try to play it through and process it since I can't do it during the day. I'm staying distracted. And so your brain brings you back to the trauma to try to make some sense of it. But then the nightmare wakes you up. So you don't actually get to see how things play out. So these are the two major theories on why it is that we have nightmares. And the treatment I'm going to be talking about in a little bit maps onto both of these in different ways. So I also acknowledge here, but wait, what about nightmare disorder? I know a lot of people are probably wondering how we can talk about nightmares, insomnia, PTSD without talking about nightmare disorder. And nightmare disorder would fit for those with idiopathic nightmares, right? If there's no known natural cause that we can pinpoint it on, sure, I would give a diagnosis of nightmare disorder. But if someone has experienced a trauma and has nightmares, their nightmares are likely much better explained by PTSD or another trauma stressor related disorder and not nightmare disorder on its own. I have worked for quite some time with people with PTSD and nightmares, and I can count on one hand the number of times I have given a diagnosis of nightmare disorder, and it's 0. So that's why I don't spend a lot of time in this presentation talking about it, because if we are working with people who have experienced trauma and they have nightmares, they're post-trauma nightmares. They're related to the PTSD or another trauma or stressor related response. So there are a few different treatment options out there that people may or may not know about when it comes to treating nightmares. The first is medication management. Prazosin or prazosin, people pronounce it different ways, is one that people often know because it's gotten a lot of good press. Whoever does PR for prazosin is working hard. It was actually created as a medication for something related to heart issues. And when they were giving it, when they were doing the trials for it, they noticed that the people that they were giving it to were having decreases in their nightmares. So they're like, oh, perfect, let's switch gears. This is now a nightmare medication. But since that time, there's actually been a ton of research that has shown that prazosin doesn't work any better than no medication. If you are someone who has worked in the VA at all, you would not know that based on the way that they prescribe this. It is given out like candy to people. They're like, oh, you have a nightmare? You had one a few years ago? Here, you take this. This will fix it now. It has really shown up as a way to treat nightmares in a way that I don't think it deserves. Because not only if it does work for the person, does it tend to work in the way that it keeps them asleep through the nightmare. So they're still having them, they just don't wake up because they can't, so then they can't remember it, then they can't do treatment. But then if they get themselves off of prazosin, there's often a huge rebound effect where they are having more nightmares in higher numbers as well as more severity or intensity. So I don't know that it's worth all the jazz around it, but fortunately, we're not in the business of doing this. So we're not out here prescribing it. But I will encourage you, if you know a psychiatrist or a doctor who is in the habit of prescribing this, to suggest that they look at the literature again. There's also cognitive behavioral therapy for insomnia, CBTI. And CBTI, I'm sure people have some working knowledge of. It involves some psychoeducation around sleep and some changes to sleep. So sleep restriction, stimulus control, those sorts of things. It can work really well at those symptoms of nightmares that aren't necessarily exactly the nightmare, but the difficulties with falling asleep or staying asleep, right? So it can add in some relaxation. It can build that sleep pressure so that the person might sleep through the night a little bit more. So there has been some decent research out there to suggest that CBTI can be effective for nightmare reduction, but it's definitely not frontline treatment material, in my opinion. There's also imagery rehearsal therapy, which is one that I've had more people tell me they know about. So this was developed by Krakow, and essentially it works on both types of nightmares based on the literature. So it can work for idiopathic nightmares, so someone with nightmare disorder. Can also work on post-trauma nightmares. And essentially what you have the person do, if they're doing this treatment, is they write out their nightmare and then they change it however they want. And then like writing it out changed and then reading the change dream to themselves. There are some other pieces of it that obviously get thrown in, but that is baseline what it is. It's being rolled out a little bit in the VA. So that's, I think, where people talk about it a little bit more. But the treatment I'm going to be talking about is one that I think works the best for post-trauma nightmares. And I might be a little biased, but it's called exposure, relaxation, and rescripting therapy. And it was created by Joanne Davis at the University of Tulsa. And here I'll take a beat and tell you why I'm touting this treatment and why we're going to spend the rest of the time talking about this treatment. Before I went to grad school, I worked in the National Center for PTSD on the CPT implementation program. So I was heavily involved in all of the data for people before and after a course of care of CPT. And I would see all of those numbers start to drop off, except for sleep disturbance. So I was really excited in going to grad school to figure out, like, okay, what can I do to make a change for that? Because I know after a bad night of sleep, I'm a train wreck the next day. And that's just one night of bad sleep, let alone day after day after day. So when I was looking for places to go, Joanne Davis really caught my eye in terms of this treatment and the different trials she's had going. So when I interviewed there and accepted my offer, I was beside myself with excitement about getting to do this treatment. And grad school's got its pros and cons, but one really good thing was learning this treatment. I was involved in several clinical trials while I was there. We've looked at this treatment in a dismantling study, as well as before or after cognitive processing therapy versus cognitive processing therapy alone for PTSD and nightmares. We also, in the last couple of years that I was there, had started a trial comparing this to CBTI so that we could start to dig in there. I think that one is still ongoing. But in my time there, I got to do this treatment with so many different people, and I got to see the huge changes it made for people in not only their nightmares, but also PTSD and depression. And it's a really quick treatment. So it got me super excited about sharing this with other people. So exposure, relaxation, and rescripting therapy, or ERT, as we call it, operates on this idea that nightmares occur in a cycle, right? And the cycle keeps going and self-fulfilling and really keeps people stuck. So this idea of how nightmares are maintained is best laid out here. Couldn't get my animations to cooperate with me here. So you got the whole cycle right up front. But essentially, if a person has a nightmare, that's going to create some sleep disturbance, right? Because they're going to be woken up out of sleep, likely in the middle of the night, and they're going to have those panic-like symptoms, those physiological symptoms, as well as those emotional ones that may prevent them from going back to sleep for anywhere from like 15, 20 minutes, all the way up to just not going back to sleep at all. So it can create huge disruptions to that sleep cycle. And then we see it creating daytime symptoms, right? So maybe the person is feeling really tired, having difficulty concentrating, having increased anxiety around like the nightmare, around their trauma, around just life in general, which then in turn can go into some increased arousal around bedtime. So I work with a lot of people with PTSD, and I often hear that basically when they turn the light switch out to go to bed is when their brain kind of clicks on. And that's the time where they're going to be thinking about everything. They're going to be replaying everything. Their bed partner might be fast asleep, but their brain has just gotten started. And so part of this is around your brain not wanting you to go to sleep because it doesn't want to have another nightmare. So all of this can lead to really poor sleep habits, both during the day and at nighttime. So maybe the person who has nightmares takes a lot of naps, which really impacts their ability to get a good night's sleep. Maybe this person is drinking a lot of caffeine throughout the day so that they can stay awake. Maybe they're having coffee with dinner, which is, if you're a CBTI person, that's a no-no. So maybe too, at bedtime, they're trying to stay up as long as they can. They're trying to avoid going to sleep for however long they're able to, because they just don't want to have another nightmare. They could be watching TV in bed. They could be reading. I one time had a person come in and be like, why am I still having nightmares? I watch TV every night to try to help me sleep. And I'm like, what do you watch? SVU? Okay. That might be part of this, right? So they might be developing these poor sleep habits, and all of this actually ends up making the person more likely to have another nightmare and keep this cycle going. And what ERT does is it focuses on every single piece of this puzzle in different sessions in different ways. So that even if one piece doesn't get addressed, we're addressing all these other ones, right? Like we can't make one thing stick, we're going to address all of it to see if we can find the best combination for the person. So I'll provide a little bit of an overview of what exactly it is that we do, and then I'm going to go component by component to walk us through this treatment. It's a manualized protocol, which has its pros and cons, but it is very flexible. You can absolutely, like, it has a set number of sessions, which is 5 sessions total. And it has those 5 sessions and content that falls within each, but it's very driven by the person that you're working with and the concerns that they have, right? Because everyone has different sleep habits, different ways of interacting with bedtime, interacting with their nightmares, different traumas. So it's very person-centered, despite being manualized. And I know sometimes manualized treatments get a bad rap for being strict, but this one's very flexible. And treatment is typically conducted weekly over the course of 5 weeks. Although one thing that we were beginning to talk about testing out before I left, or right as I was leaving grad school, was looking at potentially doing every other week for this, because there's been some good research in the CBTI field suggesting that every other week for CBTI works better because it gives the person more time to implement the changes to their sleep and actually see changes to their sleep. So I will say that that's something that could be the same here, but we aren't quite there yet. I can't necessarily say like, oh yeah, do it every other week. We'll see it. We'll see more changes. It could be. It also could not be. But it's designed to be done once a week. It includes psychoeducation about lots of things, about sleep, PTSD, and that nightmare cycle. It also includes, just as the title says, or as the name of the therapy says, exposure, rescription, and relaxation. A huge part of this treatment, making the changes that we hope it makes for the people, is homework. There is a lot of out-of-session assignments. Each week really builds, right? So the first couple of weeks, we're asking them to change sleep habits, add in relaxation. Then in the following weeks, we're asking them to read their changed dream to themselves. So I will say the times that I have seen this treatment not work as well as I know it can are with those clients who are really resistant to out-of-session assignments. But it just is that if we don't make changes to your actual sleep and the way that you interact with your nightmares, you really aren't going to see those same changes that you're hoping for. So if this is a treatment that you'd consider for one of your clients, but you know that they're not going to do the homework, I'd really encourage you to try to sell the homework as like the driving force of this. Oftentimes people who are coming in for nightmare treatment have been having nightmares for years. So I always tell them it's just 5 weeks. All I'm asking for is 5 weeks of you really giving this your all. What's that compared to the years that you've already spent dealing with this? Just 5 weeks. Sometimes it works for buy-in. Other times I still get some pushback, but I definitely try to couch it that way. We're also asking them to do daily sleep tracking. So this is very similar to like a typical sleep diary that you would give someone if you were doing CBTI. That includes time in bed, time trying to go to sleep, how long it took the person to fall asleep, what time they're waking up, if they've woken up in the middle of the night, how many times, for how long. But it's a little bit different because we're also asking about how many nightmares did the person have each night. So was it one? Was it several? We're also asking for the intensity and the distress around that nightmare. So sometimes people have really distressing nightmares. We, on the sleep log that we use a Likert scale, I believe, from 1 to 5. So sometimes it's 5 out of 5, right? It's the worst nightmare. Other times, maybe it's a 2 or a 3. We also ask on here about any instances of bad dreams. So ones that didn't wake you up. So we give that information to the client of like, this is nightmares or something that wake you up versus bad dreams are things that you sleep through. We also want to know on this sleep log whether or not they have experienced just any dreams in general, because maybe they are starting to see that they're having good dreams or neutral dreams. There's also a piece of psychoed around this is that typically people who have dreams and remember them, no one really has good dreams. Sometimes you do, but by and large, dreams are neutral or trend negative. So we give some psychoed around that as well, but it could be that over the course of treatment that we see a decrease in the nightmares, but an increase in dreams. And that's another place that we could see like, okay, we're making some headway. So now let's talk a little bit about the psychoeducation component of this, because like I said, there are a lot of different places where we're providing psychoed. We do a lot in the first session around sleep. We are talking to people about their sleep drive, pressure, and clock. For anyone who does CBTI, these probably sound very familiar. We're trying to get the person to be able to identify their own patterns of sleeping. Like, are they a morning person? Are they a night person? Do they find that they work best when they wake up early? Or do they need to sleep in until 9 or 10? Right? We're also talking about building that pressure for sleep. So wanting them to be sleepy when they get into bed, as opposed to getting into bed for 10 p.m. sake, right? I usually in this session will give kind of the overview of sleep is like filling your gas tank. You want your tank to be at full when you wake up in the morning, and throughout the day, you want it to slowly move towards empty. You want to be on fumes into bed, boom, you're asleep. If you take a nap during the day, you've put fuel in the tank. If you have caffeine close to bedtime, fuel in the tank. If you are smoking cigarettes right before bed, fuel in the tank, right? So I give that analogy. We're really trying to empower people to learn as much about their sleep as they can, because oftentimes people come in not knowing too much about sleep. They just know that they do it and that they need it, and things tend to fall apart when they don't get it. We're also providing in the second session psychoeducation around PTSD and trauma broadly. In the trials that we ran at the University of Tulsa, it wasn't always, depending on the trial, it wasn't always necessary for the person to have a full-blown diagnosis of PTSD. They might still be having nightmares, but in talking about the symptoms that occur with PTSD, it gives some context to their experience. It helps to show them that they're not alone, that other people go through similar things, and it helps to kind of shed some light on why it is that they're feeling stuck, especially feeling stuck with these nightmares. So we spend some time talking about PTSD. Also, in the third session, we provide some psychoeducation around nightmares, and that same nightmare cycle that I brought up earlier, we're sharing that with them and how we're targeting all of those places. In all of these sessions, we're talking about stimulus control and sleep habits as well, and providing lots of psychoed around how our sleep habits, both good and bad, can impact us, and how stimulus control, like watching TV in bed, not watching TV in bed, reading in bed, all of those sorts of things, looking at your phone right before bed, right? If you get your phone right here in your face, it can be very stimulating. It's not quite helpful for sleep. So we're giving some psychoed around this. And this is where we start to see our first homework assignments, is we're asking people to list out their good sleep habits, as well as the ones that they want to change. And here, you never force someone to change a sleep habit, even if, like, I'm looking at someone's sleep chart or sleep log, and I'm seeing that they're waking up all over the place. And I'm like, I know if we just set a wake time, that would be a good anchoring point and other things would fall in line. If they don't want to do it, they don't have to. But we do encourage them to pick out one sleep habit per week to modify and to kind of work on. And we give them a log so they can put in, maybe their goal for the first week was to reduce screen time for 30 minutes before bed. Each day they can fill in what they did or didn't do to accomplish that change in their sleep, so that we can start to see some changes around their sleep habits. We're also including relaxation as part of treatment in the first couple of sessions and continued throughout. A big piece that we work through is progressive muscle relaxation, or PMR. And this is because when people have ongoing stressors, they're often very, very tense, right? People are wearing their shoulders as earrings without even noticing it. And if you're really tense, that's not a good way to fall asleep. You're gonna have to relax a little bit before your brain is like, oh, okay, I can turn off. It's safe to go to sleep. So we show people how to do a progressive muscle relaxation in the first session. And then we ask them to do it every night before bed. And if possible, we ask them to do it right when they get into bed. And we have them track their subjective units of distress, or their SUD scores, before and after. I always tell people, if you are falling asleep through this, you're a 0 at the end of it, right? It is a 0. You're feeling good, you're asleep. And I don't have people get up out of bed to kind of write this down. I'm like, just kind of vaguely remember it in the morning. We're aiming for an estimate, not perfection. Same thing with their sleep log too, because some people get really hung up on details there. So really any PMR will work for this. You can encourage people to use apps. You can encourage people to use YouTube. If people do use YouTube, make sure that they've turned off their autoplay and make sure that they've listened to the whole PMR first, so that there aren't any surprises, because I've had some people get some surprises before, and we don't want surprises around bedtime. Another way that we are teaching relaxation is diaphragmatic breathing. This is something that we all do, right? We all breathe. But if we're being mindful about it and really trying to breathe deeply, it can enhance relaxation, right? Because if our fight or flight is getting activated, we can't tell our brain, I would really like my heart rate to be this many beats per minute, and I would really love it if my body temperature could be 98.6 degrees. But what we can do is we can focus on our breathing, which then tells all of those other systems, okay, I can start to regulate and I can start to relax. One thing I found to be really helpful about diaphragmatic breathing, there's the traditional hand on chest, hand on belly, see which one moves more. But when that can be tough for people, because sometimes people are like, they both move, I don't know how to get the belly to move more. I tell people to put their hands behind their head, like they're lounging in a chair and holding their head up, right? And that actually forces you to take a deeper breath. It's really hard to take a shallow breath when you've got your hands up like that and when you're holding your head back. So that's just a fun tip if you are in the business of coaching people to do diaphragmatic breathing, which I feel like to some extent we all are in different times. So we encourage people to do the PMR right before bed, and we encourage people to do the diaphragmatic breathing several times throughout the day to start to work towards overall relaxation and to start to tell our brain we don't have to be worried or on edge. So the main piece of this that we start to see the most change is when we get to the exposure and prescription piece of this. And I get really excited about this. This is usually session 3 that we do this in, so that we've got some time in the follow-up sessions 4 and 5 to problem solve this. But what we're doing in the exposure is we're really targeting that avoidance head on. People don't want to talk about their nightmares. They don't want to think about their nightmares. If their nightmares are trauma replicative or trauma similar, they don't want to think about the trauma. So what we're having people do is we have people in session write out their most distressing nightmare. So very similar to if you're doing trauma-focused treatment, you have the person pick the most distressing trauma for us to focus on. It's the same way with nightmares. If we address the most distressing one first, we are confronting that avoidance head on. And then we can start to address some of the other nightmares that may pop up. So we have people write out the nightmare, including as many sensory details as possible. We want to know what they're seeing, what they're feeling, what they're hearing. Some people report that they can smell things or taste things in their nightmares. We want those details in there. We want it to be like, I could nominate this nightmare for an Oscar because it is so vivid, right? And we want it to be present tense and first person from the point that they know they're in the nightmare to the point that they wake up. And then we have them read it aloud to us. And before they read it aloud, we talk about noticing any salient trauma themes in the nightmare. So for people who do cognitive processing therapy, these themes look very similar because they do come from CPT. We pulled from CPT for these. So we are looking in the nightmare for any themes of power and control, trust, esteem, intimacy, or safety. And before the person reads it aloud, we tell them, I'm going to be listening for these, and I want you to know this if you see any of these themes as well. And then we have the person read the nightmare aloud. So I've got an example here of a person who's written out the nightmare wonderfully with lots of sensory detail. So I'll read it aloud because I know it's a little bit tight. So it is night, and it is hard for me to see where I'm going. I'm running up the stairs trying to get away from a large man. I can't see his face, but he is wearing a bright red hat. I hear him behind me, breathing heavily, and I'm trying to run faster. My heart is racing out of my chest, and I'm very scared. I'm trying to yell for help, but my voice only comes out as a whisper. It seems like no one will ever be able to help me. I see an open door, and I go as fast as I can to get there. I run in and shut the door and lock it. I quickly hide under the bed and wrap myself up in a blanket. The man is angry and yelling for me to open the door. He's banging on the door with his fists. With each pound, I can hear the door cracking. Then the door crashes open. He runs toward the bed, and I hear him yell that I am in big trouble. So once we've had the person read this nightmare aloud, in the same session, we switch right into rescription mode. We have the person write a new dream, including those same sensory details in the present tense, in the first person narrative. We encourage them to rescript or change either the beginning, middle, or end of the nightmare, but they should keep parts of it the same, right? Because if we have that nightmare that I just read aloud, and their changed dream is that they're walking through Fort Williams and it's a beautiful, bright, sunny day, your brain's going to have no way to make that connection. So we want it to be somewhat similar to the nightmare. And we want to rescript according to those salient trauma themes, right? So maybe some safety, maybe some power and control if we're using that last nightmare. It can be realistic or fantastical in nature. It doesn't matter. It's a dream. It can be whatever we want it to be. And we emphasize here that the goal is not to change or minimize the trauma. This is a really big piece. Sometimes people have a lot of pushback around this. They're like, well, I can't change what happened. And the nightmare isn't what happened, right? Each night we're not being transported back to the trauma. It is a nightmare. This is our chance to change it in a way that makes us feel more powerful or increases our sense of safety or the way that we trust ourselves or others. We aren't changing the trauma. We can never do that, but we can change the nightmares around it. So using all of this, this person has wonderfully rescripted their nightmare to create a new dream. I'll read it aloud again. It is night, and it is hard for me to see where I'm going. I am running up the stairs, trying to get away from a large man. I can't see his face, but he is wearing a bright red hat. I hear him behind me, breathing heavily, and I'm trying to run faster. My heart is racing out of my chest, and I'm very scared. I yell for help, and my voice comes out as a roar, like a lion. My roar transforms the man into a squeaky little mouse. I pick up the mouse, and I see an open door, and I go as fast as I can to get there. I run into the room and grab the mouse cage from under the bed. I drop the mouse in and look the mouse in the eyes and say, "You are in big trouble." So here we can see this person decided to rescript the dream in a more fantastical nature. They were able to transform their perpetrator, predator into a mouse. They were able to have some power over the situation. They were able to increase their safety, right? And they did it in a fantastical way. They kept pieces the same, the beginning and the end, kind of throughout the same. And what we would do for this person, and for anyone going through this treatment, is we would have them read this changed dream to themselves every night before bed for 10 to 15 minutes to really try to tell your brain, I've solved this. I don't need to have this nightmare again, because look, I did it. I've solved it. We don't tend to see people having their changed dream as an actual dream, but we do see a decrease in the severity of nightmares, typically first, then an increase in a decrease in the frequency. And people maybe they've gone home and they've read it aloud to themselves, and something still doesn't feel right. We can kind of fix it in the follow-up sessions. So if we're tracking all those other pieces of homework, they would do their reading their changed dream, then they'd get into bed and do their relaxation. So going back to that cycle and how ERT breaks this cycle, we can see that it addresses nightmares through the exposure and rescription piece. It addresses sleep disturbance through that stimulus control and changes to sleep habits. It changes those daytime symptoms, those feelings of feeling on edge, and the increased arousal near bedtime through those relaxation activities. And then it changes those poor sleep habits through psychoeducation. So I know we are coming right up to time, so I want to be mindful and open it up to any questions, knowing that I gave you a bird's eye view of all of this, but just know I'm happy to keep talking about it anytime. So I'll stop sharing my screen so I can see all of you and take any questions.
Yeah, we do have one about when you're doing the rescripting, essentially like how much you really let the client do that, and feeling like it's probably more powerful if it comes from them, but also folks might be sort of unsure about how to change elements or kind of what to come up with.
Yeah, absolutely. I strongly encourage you to let the person struggle with it if they need to struggle with it. In the manual itself, there are different examples that we provide leading up to it to kind of give them a jumping off point. But I know personally in my clinical work, I've had clients where I'm like, I just don't know how we're going to rescript this. I cannot see a path forward on this. And then I give the assignment in session of like, all right, floor is yours, rescript this. And they take it away and they really surprise me. But if they're really struggling, then I bring them back to those themes that we identified and be like, okay, so if we're working around a feeling of powerlessness, how could we change this so you feel more powerful? What would be a way that you could take back some power? So that's where I will give suggestions through like a reminder there about the trauma themes. And if I'm really pushed to, I may give one example, but usually it doesn't take too much poking and prodding.
I have a question, Chelsea. I'm just curious if you have used this with people who have idiopathic nightmares rather than trauma or kind of post-traumatic. I'm just curious. I don't actually see a ton of barriers to using it with people with idiopathic nightmares, so I'm just curious if you've tried that or if there's research on that.
We have not done it with individuals with idiopathic nightmares, at least at this point, since we do want to rescript around those trauma themes. But it's very, like my brief description of imagery rehearsal therapy, you're essentially doing the same thing, just without the trauma themes that you're rescripting around. So it wouldn't be that much of a push to kind of allow the person to rescript some of their nightmares. It just may not have that anchoring point of like, okay, if we're dealing with these trauma themes, how would you do it?
Yeah, if I could pipe in, Kate, I've done this. It's not trauma related. I would consider this more idiopathic. So my question, Chelsea, and it's kind of on this. I've found this technique difficult for when for nightmares that vary in terms of theme or content. Like it's very difficult to do this when the nightmare is such a moving target. So do you have any kind of guide on that?
Yeah, I have worked with several people who have a variety of nightmares, and they're like, it's always changing. I don't know what one to do. I'll encourage people. I'm like, usually there's one or two that you're like, I wish I don't, like, I hope I don't have that again. I really hope I don't have it again. And even if it's not one that's come up recently, I encourage them to do the one that they really want to avoid having. And then they do that one first. And then in the follow-up sessions 4 and 5, we can do the more regularly occurring ones.
What is kind of if someone was interested in doing this, for example, what would the recommendation be about kind of the level of, I guess, like didactic training? Is this something where, like a lot of, for example, the treatments that work manuals, like we could pick up a lot of those and sort of read through the manual and do it. Is this something that falls more into that camp, or is it more like it would be advised to do some sort of guided like didactic training before you attempt to incorporate this into your work?
I mean, if you talk to Joanne, she would be like, take my training. But she also has a book published on this that lays out what happens in each session. Although I will say the book, which is called Treating Post-Trauma Nightmares, a Cognitive Behavioral Approach, is based on a previous iteration where it was only 3 sessions. And that felt chaotic. I'm trying to fit everything into 3 sessions. So now knowing that it's kind of 5, you could go based off of the manual that is existing out there in the world, or you could go for a training. But I think realistically, you can consult with me if you wanted to.
All right. Well, we are about at time for today. Thank you all so much for being here. Next month, it'll be Julie giving our yearly wrap up. So Julie, we'll see you next month to talk about where we've been and where we're going. Yeah, and if folks have questions, please reach out, let me know.
Thank you. Thank you, Kelsey. That was great.
Yes,
Awesome.
thank you.
Thank you.